Hello, I'm Martin Wildman. I'm a consultant in respiratory medicine and adult cystic fibrosis. I've got a background in health services research and public health, trained at London School of Tropical Medicine and Hygiene. I'm going to talk to you today about optimizing self-care in long-term conditions using an archetypal learning health system called CFHealthHub. The context of this work is that within the health and social care budget, 7 out of 10 pounds of that budget is spent on long-term conditions. So that optimizing care for people with long-term conditions is an important policy goal. Patients with knowledge, skills and self-efficacy for self-care are able to shift most of their consumption of care from rescue to prevention. And so as an objective, this was one of the very important things that we focused on in building the CFHealthHub Learning Health System. The CFHealthHub Learning Health System is a health system based within cystic fibrosis, and cystic fibrosis is an archetypal long-term condition. One of the advantages of cystic fibrosis is that the care is delivered in 26 tertiary care centres across the UK, which gives us a relatively focused area within which to work. And I'm going to signal how a coherent conceptual framework can be used to build a learning health system. So in terms of the learning health system design, we did some really detailed pre-work where we sat down with clinical teams to understand how those clinical teams considered that the delivery of care could be optimized. We created a logic model, and within that logic model, we identified areas where data captured using digital techniques could be used to help people to focus on what is typically out of sight and out of mind in long-term conditions, which is prevention. And in order to do that, we created a purpose. Our purpose was to enable people with CF to live as normal a life as possible, essentially by empowering out-of-hospital prevention. So the logic model was our understanding of the system so that we could understand where to place data in order to prompt attention. This is a diagram of the process that we used, and what this diagram is capturing is the MRC complex interventions pathway. The MRC complex interventions pathway is a way of creating complex interventions. We believe that learning health systems are archetypal complex interventions. So what you can see on this slide is that we started with 15 months of co-production of the intervention. We then piloted that in 2 centres in a randomised controlled trial, but that randomised controlled trial was primarily about mixed methods process evaluation, what works, what doesn't work, and in terms of what works, it's what captures people's attention and what data enables behaviour change to optimise the system. We then tested that intervention within a 19-centre randomised controlled trial with 600 patients, and that demonstrated that the learning health system was able to support the creation of habits, the creation of knowledge, skills and self-efficacy and self-care. In parallel with that, as well as the randomised controlled trial, we were setting up a learning health system. So the first centre where we did co-production became the first centre in the learning health system, then the 2 pilot trial sites, and then the 19 centres from the randomised controlled trial, which gave us a learning health system which was really fully up and running in 2019, but had been collecting data since 2014. Within clinical systems, we are so often focused on the immediate. And so when it comes to building a learning health system within a busy healthcare sector, we have to think about the science of attention. Rescue's easy. Rescue comes to us with patients who are sick and it's easy to pay attention to them. But for those patients in whom we are supporting prevention, that's the 365 days of self-care for long-term conditions, paying attention to that for clinicians in hospital is much more difficult. How do we pay attention to people who are otherwise out of sight and out of